So this is the video presentation how I do it. It is a cholangioscopy, also known as cholangioscopy. I already talked the surgeon's perspective on this. So this presentation is all about how we deal with the CVD stone in our setup. So we all aware of this anatomy, and we know the ball stone in this part of the below the cystic duct is we can deal with the ERCP, but the ball stone in the part stuck in the right and left hepatic duct is required some another thing to do it. So what is the cholangioscopy? The cholangiography is just a radiological visualization of the common bile duct, and the cholangioscopy is direct visualization of the common bile duct. It's a difference is like barium enema and colonoscopy. So we all know cholangiography or ERCP, we put the contrast through the ampulla, and we visualize the whole part common bile duct over here and the pancreatic duct. And we can visualize the stones and strictures from the cholangiography. But cholangiography or ERCP is simple, no additional endoscope required, and does the most of the job in the most of the cases. But the disadvantage is when we have a large stone, it is very difficult to remove by the basket or by the balloon. So we require electrohydraulic lithotripsy or laser lithotripsy for this. Or also disadvantages for this cholangiography is characterizing the stricture, whether it is a benign or malignant. So in benign, if it is a stricture like it is a malignant, then if we require the cytology or biopsy. So if we will do the cytology using cholangiography, this is sensitivity is only 30 to 40%. If we do the fluoroguided biopsy, then sensitivity is 37 to 65%. So now that's why the cholangioscopy comes to the picture, and the cholangioscopy is just to see the bile duct. So we can identify here where this stricture is benign or malignant. So what are the types of cholangioscopy? So routinely this procedure in our setup, this is especially for the surgeon. So during laparoscopic cholecystectomy, we introduce cholangioscopy through the cystic duct stump, or if it is cystic duct is very narrow, then we introduce our cholangioscope through the small incision in the CVD expression. We also do it in the open surgery when this indication is not because of this. The indication of open surgery is during the cholecystectomy, when there is a megazy contracted gallbladder is there. When we are opening the case, then we use cholangioscopy. When there is an impacted stone on inside the liver, right or left hepatic duct, or failed ERCP in cases of failed ERCP. So again, we can put our cholangioscope through the T-tube or transhepatic. We are doing this one, the laparoscopic mode. We are putting our cholangioscope through cystic duct or then through the CVD. So pulpolar cholangioscopy, if you have talked, there is a two type of pulpolar cholangioscopy. One is mother-daughter and second one is a direct cholangioscopy. The mother-daughter has again the two types. There is a two-operator system or single-operator system, also known as spyglass. Two-operator system, the cholangioscopy requires one ERCP side view endoscopy, and there is one more scope over here which is going inside the ERCP biopsy channel, and this is mainly used for the large impacted bile duct stone for the lithotripsy. And the limitation is we require two endoscopies and two tower to set up, and this is a time consuming and very small caliber to work. And now this next system is spyglass. This is single operator. We are using in our setup this thing, the spyglass. This requires only one surgeon. This is a ERCP side view scoping, and this is a cholangioscope which is going inside through the biopsy channel. So this comes out from the side view endoscopy. It has a camera, light source, and it also has a small channel which we can use the biopsy forceps. The basket also is come and is near. So parallel cholangioscopy, it is very easier to perform, and the better image quality, larger biopsy we can take, and it has also both channels for suction and irrigation. And the per oral conjugate, some limitation is there. There is a image is still not good if as compared to direct cholangioscopy. It is little bit expensive and limited accessories are available and no narrow band imaging between. And the second one is the direct cholangioscopy. The direct cholangioscopy is single ultra thin scope which we inserted directly through the mouth and pushing it inside the CVD. It is very difficult to do it. It requires using a guide wire or balloon guided insertion inside the CVD. So spyglass, it is available since very long, and direct cholangioscope very limited data. This is a new technique is available right now. Spyglass is technically easier. Image quality is not so great as compared to direct cholangioscopy. Limited accessories and it is expensive. And if you talk about the direct cholangioscopy, it is a technically difficult. Image quality is better. There is a multiple accessories present and relatively cheap. And one more important thing is direct cholangioscopy. We have narrow band imaging with this. So we can see the view, the quality of image. This is spyglass. This is a cholangioscopy. And the cholangioscopy mainly used for the evaluating the structure. The main use is evaluating the structures and the diagnosis and staging the bile duct cancer, detecting the large stone, finding the cause of recovery bile duct stone, and selective stenting of intrahepatic duct if required. So this is the pictures of cholangioscopy where we can see there is a strictures, there is a cholangiocarcinoma. And with this, if we took the biopsy using the cholangioscopy, the sensitivity which was earlier in the cholangiography lasts for 60 to 65%, now it is increased to 85 to 95%. So in direct, this is present only in direct cholangioscopy. We have narrow band imaging where we can identify the cholangiocarcinomas using the narrow band imaging. So this is a picture. This is a paper published by from the Japan where there is cholangiography versus parolar cholangioscopy is evaluated for intraepithelial tumor spread in bile duct cancer. Only ERCP is only 22% sensitive. Parolar cholangioscopy alone is 77%, but parolar cholangioscopy with biopsy is almost 100%. So as we can see here, we can see impacted large bile duct stone inside the CVDs, slugs. And if required, we can remove it through the lithotripsy. We can use a medical lithotripsy. In our setting, we are using the same holmium laser which we are using for the electric stone. And after breaking the stone, we can remove it with the retrieval mesh or retrieval baskets. And we can also do the balloon dilatation with the intrahepatic duct, or we can also use the stent with this. So I'll show the small video. This video is so this is the parolar cholangioscopy we are doing using mother water technique. And this is the ampulla. We can identify the ampulla over here. And this is the scope, ERCP scope. And we are using the spyglass through the biopsy process here. So this is a spyglass in my one hand here, and this is a scope. And now I am calculated the spyglass through the ampulla, and there is one more monitor over here. Here I can see the inside the common bile duct. This is cystic duct opening. This is common bile duct. I'm really sorry for the quality of this photo. Please concentrate on. So, and with further reducing, we can identify the right and left hepatic duct. So this was the case of small stone on the MRCP. When we introduced the camera, there is no stone was found. Probably stone was passed before the inserting the cholangioscope for you. This is right and left hepatic duct. There is one more video where we inserted this during the laparoscopic cholecystectomy, and we inserted the spyglass through the cystic duct stem. after opening the cystic duct. So we are inserting, this is a gallbladder, this is a gallbladder, and we are inserting it into the cystic duct system, and we are looking inside. This is a duodenum, and we are coming out. This is a sphincter of our guy here, and while coming out, we are looking carefully if there is any stone here. So while coming out, we can see there are multiple sludges over here, and there is stone inside the common bladder. So we will do this stone using the Dormier basket. So this is the next picture which we are putting through. This is one more picture. Now this cystic duct is very narrow. That's why we make a small opening through the common bile duct, and we are putting the
Dr. Hari, please conclude.
Yeah, this is last video, sir. Just for you. So we are putting the radioscope through the opening in the common bile duct. So this time we are going up towards the liver. This 30-second video service. Last video. So this is right and left hepatic duct. We can see over here. This is a large impacted stone over the right hepatic duct. This is ERCP patient came to us, and we are using. If it is a soft stone, it can be easily breakable with using the basket. If it is the hard stone, we use a laser lithotripsy. We are taking out the stone using the basket. The same, now we are sending distally towards the duodenum, and there is a stone over the part of duodenum. So that's all.
Please continue.
We are trying to catch this within the basket, and we remove this stone using the basket from the CVD. And we mostly we close this CVD without putting any stent in the common barrier. Thank you.
Very useful presentation by Dr. Bobia about various aspects of diagnosing the biliary diseases. Thank you very much for the nice presentation.
Thank you.
Thank you.
Thank you, sir.